Good evening. I'm Dr. Tara Sampali, Senior Scientific Director with Nova Scotia Health. I'll be your host for this evening's Open Dialogue Live event, Data and its Impact on Health. And being in Nova Scotia Health and working for the province, I can tell you this is a very important topic and there are multiple strategic priorities aligned with this. So I'm delighted to be part of this event. Tonight's discussion is part of a public series connected to Here We Code, a campaign to position Nova Scotia as one of Canada's top digital ecosystems, celebrating success stories and showcasing how digital is impacting the world around us. As the COVID-19 pandemic continues, and as we prepare for the inevitability of future public health crises, the intersection of public health and data privacy will remain critically important. Learning the lessons this pandemic provided will protect us in the future. Tonight, we'll explore the topic of health data in relation to the privacy and access concerns and how it impacts public and individual health. Please welcome your panelists for this evening. Professor Carla Heggie is a certified information access and privacy professional who's been involved with the development, writing, delivery, and teaching of information management legislation and policy for over 34 years. An adjunct professor, instructor in the faculties of computer science and management, she teaches 5 different courses in privacy. Her company, Teal Creative Thinking, offers consultation in the areas of information access, privacy, policy, process, and patient advocacy. As someone with a chronic illness, she has more than enough experience with most levels of health administration and the use of personal health information. Welcome, Professor Heggie. Dr. Finlay Maguire is an assistant professor in the Faculty of Computer Science and Department of Community Health and Epidemiology. His research involves using genomic data to better understand infectious diseases and the collaborative application of data science methods to social and health-related problems. Dr. Maguire has co-developed widely used SARS-CoV-2 analysis, metadata, and quality control specifications and tooling. Welcome, Dr. Maguire.
Thanks.
Dr. Samuel Stewart is an assistant professor in the Department of Community Health and Epidemiology at Dalhousie University and is the Director of Health Data Nova Scotia, the provincial repository for de-identified health administrative data for the purposes of research. His research areas include secondary data analysis, natural language processing, machine learning, decision support system, and meta-analysis. Welcome, Dr. Stewart.
Thank you.
Yeah, and welcome to you all. So to begin with, we'll have a discussion among our panelists, and then we'll definitely open the floor to you, to the viewers, to questions. So I'd like to start by asking a question each to our panelists, and I'll open the questions then to the others to respond to the same question, and following which I'll have 2 open questions for all the panelists to respond. And following that, of course, the most important aspect is to open to the viewers. So I'd like to start with Dr. Sam Stewart. Sam, what is big data and how is Dalhousie positioned as a leader in this space? And I'm going to ask as well, what has the pandemic taught us about health data and what considerations does this raise for the province to take in terms of privacy legislation and others related to machine learning? Over to you, Sam.
Sure, thank you. So big data, big data is a challenge. Lots of people have different definitions, and I'm not going to get into the 3 V's, 4 V's, 5 V's of big data that I'm sure a lot of people in our audience are familiar with. Feel free to look them up if you're interested, or ask some more questions. We can talk about it later. For our purposes, take a more general view, big data is data that takes different forms than we're used to in traditional spreadsheet or relational databases. And it's data that is a challenge to work with from an analytic perspective, whether that's because there's too much of it, or it's coming too fast, or it's coming in formats that's not manageable, or it needs analyses that don't fit within the traditional statistical or even computer science models. big data is data that we can learn from, but maybe not in the ways we've learned before, in the way that even I was trained several years ago. In terms of why Dow's positioned well as a leader in this space, there are a couple of reasons. We have Nova Scotia is an excellent environment for this. We have a lot of higher learning institutions that are very collaborative. There's, I sit on committees that things like ACENET, which is a maritime-wide, Atlantic-wide high computing institution, collaborations across the universities. We have active and ongoing dialogue with our provincial government, which makes it easier for things like new investments into computer science. As well, at Dow specifically, we have a very strong computer science, statistics, mathematics, physics departments that are really focused on this kind of high performance data. When we look at, as an example, when I look at kind of what fields at Dow are accessing the high performance computing at ACENET, it's a variety of things from oceanography to chemistry to health. So there are a lot of people interested in it. We have the resources to manage it. And it's a very collaborative environment, which is not necessarily, I'm not going to throw shade at other provinces that are not collaborative. I'm sure everyone thinks they're collaborative, but we are in Nova Scotia. It's a really great place to work together. And I find it's rare that you get into a room where people are protecting their fiefdoms. They really want to work together. That being said, when we talk about the pandemic and health data, wanting to work together and being able to work together are two different things. And we have certainly, Dr. Sampali, you could probably answer a lot of this work from NSH. So one of the things the pandemic's taught us about health data is just how much varied health data there is and how much we're not necessarily taking advantage of all of the private data that's available and also all of the public data that's available. And there's a lot of public data, whether it be, data reported. We saw some of the excellent work that was being done out of the US in terms of like international monitoring of COVID rates, but also individuals monitoring data. So we had a hard time making use of self-reported data during the pandemic. And I think that's something that we'll see a lot of work on moving forward is ways for me to get data to my GP and my specialist in a way that they can use it. I have this great smartwatch that has monitored my heart rate for the last 8 or 10 months. I got it last summer sometime. No one's using it. It's not useful to me other than know that I get really worked up when I'm using my stationary bike, but my doctor has no ability to leverage that. And that's true of, if you look at some of the directions for, so I was diagnosed with COVID on Saturday, so I'm in the middle of my quarantine right now, and there's no way for me to report the status of my symptoms. So the optimal way for me to be managing my condition would be symptom management rather than kind of the base timelines, that kind of reporting back isn't well equipped for this system. The other thing that we have a problem with, and this is where I talked about collaboration, is that our legislation isn't necessarily well equipped to support the sharing of data for exploratory research. And I think that's one of the biggest problems, as at Health Data Nova Scotia, we run into this problem. We have good public health, we have reasonable public health legislation in Nova Scotia. The PHIA legislation, PHIA, is pretty, it's okay. It's not better or worse than what we see in other places in the country, but it's very hypothesis oriented. It was written in the early 2000s, and it's very much, if you know what you want to do research on, we'll give you the exact data to do that research. And in an exploratory machine learning, computer science, even statistical learning is often exploratory, it's very difficult to write those hypotheses. And it's whether it's a matter of the way the legislation's written or the way that it's interpreted at DHW, it's a little bit of both. But I think one of the challenges we run into is that kind of exploratory research is difficult to pursue in the current environment. We have really good safeguards in place for ways to pursue that research in secure environments that can protect individuals' privacy, but enabling legislation to support that and understanding what it means to perform machine learning and develop, if you develop a deep neural network on public health data and then take that neural network out of the secure infrastructure, what does that mean in terms of the privacy of the participants? How much of the participants' identity and essence is captured within that neural network, and is there a risk of compromise? So there's, from both sides, from both the science perspective and the data management perspective, there's a need for a little bit of growth.
Thank you. That was great. Does anyone want to add, Professor Heggie, Dr. Maguire, anything to add to that question?
Like one thing I would jump in there that is, I think, an interesting problem that doesn't get discussed is we're very focused on the data and getting access to the data. But I'd say a key component of a lot of that data is in the expertise and a lot of the nuances in the way that data was collected. That tends to be like the original organization tends to have that context information that's not always captured very well. You know, the best metadata scheme in the world and the best descriptive scheme in the world doesn't always capture it. So there are definitely, and we've all seen it, of like, open data is great. Like, I don't think any of us are going to be against open data or not very pro open data. And like gatekeeping has a huge problem. But being able to have like a better format for interfacing with the expert that originally developed the data that has those nuances and tapping into that before you you do your exploratory analysis, but like, okay, is there anything I'm missing or I have not understood with this data? And so I think that's a component about the data access discussion that like, how do we make that less painful? How do we reduce friction for that is an interesting component.
Yeah, and I think, Tara, that Sam hit the nail on the head when he talked about how the legislation is interpreted more than how it's written, because it is written to allow for interpretation and discretion to be applied, and it's been around since before this century. So it's, but how it could be changed, that's probably a whole new discussion as well. And I think the government's looked more at the access side than the privacy side over the years. And it's a matter of who is at the table in doing the interpretation. It's still a niche field.
Again, the great point and a great segue to you, Professor Heggie. So let's talk about that. How are people being engaged, about in the collection of data, thinking about those proactive measures, thinking about those sharing agreements, and all of you kind of reference that. And within this, can we also think about, what about how does lack of knowledge or perception of knowledge, lack of understanding about privacy, all of this, how does it play out in really trying in our engagement approach?
I think one of the biggest things that I face as a privacy and access professional is the perception of knowledge. Everybody thinks they know what privacy is. And I mean, we've seen that comparable argument, I think, during COVID in the health field of people wanting to go to the internet and do their own research because they don't believe the professionals, the health professionals. In the same way, there's very few far between privacy professionals and access professionals. And we can say, look, at that tracking system, that app is good. We don't believe you because it's my privacy and it's going to be breached. So I'm going to go do my research on legislation that's based in other countries. And we have problems with some of the professionals interpreting legislation and some of the lawyers in the courts, as opposed to the members of the public wanting to do that. So I think perception of knowledge is a big issue in privacy to begin with, and information access. And it seems to have been made worse during COVID because people are in panic mode. They were at home. What else are they going to do? They're going to go on the internet and they're going to try to make their own decisions based on a faulty foundation because they don't have the knowledge.
Thank you. I think all of those are great points. I'd like to welcome Sam or Finlay to add to that.
Yeah, I think the idea of not understanding the kind of the details of privacy with relation to research. I find sometimes some of the most challenging people to work with in terms of health data research are health practitioners, because they get in this really weird situation where they're allowed to look at data on an individual level, and then they need to file a privacy impact assessment to look at that exact same data on a research level. And it's the nature of legislation, but also rules around, you have access. All clinicians have access to the drug information systems. If I go into the ER doc can look in the drug information system to see what prescriptions I have. But then if they want to then enroll me in a research study, what do they need to do to get that same list off the drug information system for the research study? And there's often a lot of confusion or misunderstanding where you can log into it with your clinical hat and not your researcher hat, and it can be very frustrating for people that they need to file a PIA to look at something that they are looking at right now, or they can see the data on a single level, but at a population level, they need to get special permissions. I think one of the things we've been finding, so I'm part of a Health Data Research Network Canada, is the network of data centers that are like HDNS. So ICES in Ontario, NBIRDT in New Brunswick, Manitoba Center for Health Policy, like every province has their own. And they've been talking about, they've been doing a lot of research on this concept of social license and what citizens accept or think we should do with their health data for the purposes of research. And it's really fascinating. They've published one paper, they're going to have a white paper out soon about kind of these tiers of what they think is acceptable and isn't acceptable. And there are certain things that they think we're already doing. There are certain things that they think are okay. And there are certain things that they wholesale disagree on. And some of the things that they think should never be done are done in other countries. So it's, they absolutely don't want their data sold to private vendors, right? They don't want their data sold to IBM so that IBM can operationalize it. And in the US, then there are research groups that will brag about being able to sell you X number of electronic medical records for the purposes of research and model development. So it's difficult to get that knowledge out there, and we need to work with people to let them know kind of what does and doesn't work from a privacy and access perspective.
Thank you, Sam. And I know Carla will come back to speak about this, but definitely anything to add before I go back to Carla?
Yeah, and I think one of the interesting things, and I'm sure if there's any lawyers or legally minded people in the audience, and I'm sure Professor Heggie has experienced this many times, but one of the interesting parts, especially around the legislation, is reading between the lines in legislation. Especially, now, we're a researcher. We're not an expert in privacy. We're not an expert in the legislation. So we read the legislation and believe what it says, rather than not understand, again, the context in which it was written. So, I mean, the pandemic has been a learning experience for me as someone that has to do their citizenship exam for Canada soon. I've learned a lot about the interprovincial legislation and the federal provincial legislation. And there's a lot of powers that technically exist, but aren't used on the understanding that they won't have to be used. And so just like understanding like those kind of layers of complexity in even apparently simple legislation, like the federal government has rights to all of the data from the provinces in an infectious disease outbreak. But the reality of how that emerges and what actually happens being very different. And that's where you do need, the legal experts and the privacy experts that have the context in which legislation was developed and written, how it's actually used in practice, and that ability to read between the lines.
Thank you for that. And I think, Carla, over to you.
I will always have a job. If they're reading behind the lines, the first thing we say, Finn, is the answer is it depends. It depends because it is discretionary. And we don't have enough time for me to say or to explain why this is part of the strength of the legislation. We don't want it to be black and white. It would be far worse for researchers, for the members of the public. But a lot of people have already properly consented to the use and collection and use of their personal information. It's a matter of, one, awareness, education, and doing it right at the front end, designing privacy by design. So if you use the components of privacy by design, which is a framework used globally, but how do you get that across to the members of the public or the patients? And I understand your frustration from a research standpoint. Most of the people who would come to me, both when I was in the private sector, public sector, and now academia, saying, my privacy's been breached. It hasn't been breached. They've consented to it. But there's a lot of backpedaling on it and trying to prove that you have every right, as Sam said, to use this information. The CIHR, the Strategy for Patient-Oriented Research, SPORE, we're trying to do a lot of work with that, trying to educate the patients. Unfortunately, it tends to be the chronic patients that get it. Somebody who's never been sick before walks into a hospital, an emergency room, they're going to be terrified, and they've been taught that their personal health information is so very sensitive, which it is, but we want that shared with the researchers, with the clinicians, with the people who are going to save our lives. And with the tracking systems in COVID, actually some privacy professionals, a group of us across the country, we actually went onto social media saying, hey, look, this is the app that I'm using. And if it was a privacy issue, I wouldn't be using it. So little things like that. And by the way, Sam, I can guarantee your personal health information on your watch, it is being used by the tech giants.
No, I meant by anyone that can help me. That only helps them.
That is great. I mean, fantastic points. And of course, Dr. Maguire, I'll come to you now, and definitely looking at the challenges with the genome data and how do we really link it to make it useful epidemiological metadata. So thinking about that and the considerations that we are learning lately on how we need to really make that, how it's been traditionally used, and how we can really, how it's deposited in open, unrestricted databases, and really what we're learning through the pandemic, the access, the inequity, and those types of things. So how do we ensure that, this is usable, distributed data collection by people across the globe, and you have a range of users and backgrounds and fields? So what are you thinking are our opportunities, but also the next steps?
Yeah, so especially pathogen genomic data is in a very interesting position because you have some very different cultures with very different expectations, as you would do with many other types of data, in terms of how that data is treated. And particularly in the context of, so generally, from a research perspective, and even really in a clinical perspective in a lot of cases, because it's not human genome data, it's kind of considered as, it's not sensitive as long as you've stripped out the human information, as long as the metadata has been processed appropriately and anonymized to the right degree or fuzzed to the right degree, etc. It's not considered that sensitive generally. So on a research end, we tend to upload all of the data to these big INSDC databases. There's one in the US, there's one in Europe, there's one in Japan, there's a Chinese database, which is kind of affiliated. They all have mirrored data to one another and have standard access. And it's basically it's an expectation if you're publishing anything that it goes into these databases and it's used there. What's kind of come out of the pandemic has been the kind of collision with the flu world in particular. So one of the issues with flu that's come out with flu genome sequencing has been, it's long established that, there's flu surveillance globally, WHO supported programs that are largely funded by individual nation states, where, there's surveillance of local flu strains, there's genome sequencing that gets sent to kind of central collaborating centers in the WHO, which then is used to develop things like what is going to be the vaccine candidates for the next year based on what flu strains are circulating. And there was a big kind of blow up in this because Indonesia said they were going to no longer be sending their data and asserted data sovereignty over that genomic data, largely in response to, I believe it was Pfizer, possibly libel, we'll see. But one of the large drug companies developed a vaccine that then was priced or not made available to Indonesia that was based on Indonesian strains. So that's what triggered the assertion of the data sovereignty. And it led to like a lot of international politics, international diplomacy, new treaties, debate over whether previous treaties were being used in an appropriate manner. But the end result of this was the development of initiatives like GISAID or GISAID, this alternative database, in which the uploaders retain ownership over the data. And in theory, everyone can access the data, but if you want to use it for things, you, in theory, have to get permission, and there's still ownership by the original uploaders, which has its benefits. And, definitely, like, there is a strong argument to be made, especially in equity, global equity and stuff like that. It, protects the investment from low and middle income countries and their data to retain that ownership and not just be exploited by large multinational drug companies and priced out, as we've arguably seen with vaccine availability globally. So has it worked? But I think I come from the open, the kind of classic of computer science kind of hacker, everything should be open and free, that kind of very GNU 70s kind of strand. And I think, and there has been a lot of tension over these two conflicting database paradigms and how that data is shared. I mean, I think my own personal biases is like, I think I see very strong reasons, but I do also see it a bit like the kind of this form of data sovereignty kind of solves the wrong problem. It's a bit like, if your sheep are being attacked by foxes, you don't put armor on the sheep, right? It's not going to solve the well. The sheep are then going to have to struggle to move around, and including all of us in this. It adds a lot more complexity and difficulty to navigate the system, which tends to advantage the well-resourced groups far more in countries because they have the resources to navigate those additional barriers and hurdles, even if those hurdles are put in place to protect groups that don't have the resources. So that's my own particular bias in that. And like, it's one of those, it does become very heated, and there's a lot of issues with data colonialism in the past, and this is what this is related to. But it has led to some very interesting conflict. I think one of the interesting broader kind of steps from that is, as we now have this form of data sovereignty being expressed, it's bringing the discussion of, do you own your bacteria? So the bacteria or virus that's affecting you, do you own that data? Do you own that information as an individual? Historically, no, and it's not really been treated like that, but it's becoming increasingly important in health, increasingly discussed in health. Pandemic being a very key example, but there's the broader area of microbiome research where we're looking at all the bacteria and microbial eukaryotes that live in your system and things in your system and have impact on your health. So there's been like it's very interesting to see how this has emerged. And then there's a whole other aspect which I don't have time to talk about, which is the culture of the public health, the classic epidemiology data, and linking to the genome data, and how we've managed that. So there's been a lot of push to share genome data, and there's definitely been sharing of data that, for good privacy reasons, has been shorn of so much context, it's maybe actually more misleading than useful. And it's just very challenging to navigate that. I'm sure there's lots of nods, so I'm sure there's some strong comments.
So I'm going to say, Sam and Carla, do you have anything to add?
Yeah, I think a couple of things. So Finlay's last comment there about the idea of we talk about this divide between anonymous and de-identified data, which I see everyone nod. The speakers, you guys know what that means. Most people don't. Those words kind of mean the same thing to most people. So if you're not familiar, de-identified data is that's the data we have at Health Data Nova Scotia. That's data that's had identifiers removed, but through a process of either linkage, you could get back to identification, or you could re-identify the person just based on the aspects of the data. If I looked through the data, well, since I've recently had a diagnosis, if I looked for all the 37-year-old males that had a COVID diagnosis on the weekend, I could probably identify myself in the data. So de-identified data is data that's had identifying information stripped, but could be re-identified. And anonymous data is purely anonymous. Like it's data that really can't be re-identified. And part of the reason that the sharing of genomic data has been so successful is that they've really committed to that completely anonymous. Like it's not just that I see Finlay, like if you sit long enough and think long enough about it, nothing is anonymous because the genomic data is so accurate that you could probably identify enough. For a lot of them, you could identify the age and enough comorbidities. But from that's always been the principle, and we deal with this at the health ethics boards as well, as this idea of, if it's anonymous, we're much more open with its movement. So the move to make data anonymous is to really just cut it off from anything that could ever be identifying. But then that means that you are limiting its usefulness in the future in order to make it more accessible in a more open environment, where if you kept it in a de-identified manner, then it would be easier to link it back to administrative data. So you could link those genomic indicators to health outcomes in the health record, but that's not what we've done, because we want to make this data anonymous so that it's easier to move it around. The other thing I thought Finlay made a great point was this idea of using open data for, in essence, using open data for profit, or using that. We see this, Finlay mentioned new, and the anyone who's ever looked at an open source license for their software or their data knows the challenges between, Creative Commons 1 through 4 with some decimals, and the MIT license, and the various new licenses, and the challenges they have and this isn't even, it's not even necessarily a copyright issue. They're the funders. So NIH and CIHR have also looked at the fact that they provide government funds to universities to develop research, which then result in spin-off companies that the professors then make money off of, and that money never gets funneled back to CIHR, right? CIHR doesn't make these grants as an investment, but maybe they should. And there are big billion-dollar, Pfizer and private pharmaceutical developments that, in some cases, 50% or more of their development was supported by NIH grants. And then when it comes time to make a profit, NIH doesn't factor into those profits. So the uses of open data and even open source software are interesting in this environment. And what does it mean if you leverage this data? Like if we let IBM train their machine learning algorithms on our patients so that they can provide better predictions in the future, and they then sell us those predictions later on, like, we should at least get a discount on those predictions if they were trained on our data, right? Like, we're stakeholders now, but are the guinea pig stakeholders? I guess is the question. And guinea pigs isn't fair because they're not testing anything on us. They're testing things. They're running models. They're not putting us at risk the way we put guinea pigs at risk in experiments. But there's still that question: is if we train computer science or deep learning models on our data, and then predict things on new data and sell those predictions back to the people that trained the original data, does that make sense? Is that fair?
Thank you, Sam. And Carla, did you want to add to that?
Yes, please. Speaking as a guinea pig now, as a research subject and a patient, I could make the argument to say that research using my information is actually going to be of benefit to me, but that's because I have chronic diseases. But I'm glad that Sam brought up the concept of anonymous versus de-identified, because you're right, most people don't understand. A lot of people say, oh, I take your name off, I take your contact information off, it's de-identified. And I think we need to go all the way back to square one and say, when we're talking privacy, what do we mean? We're talking about personal information that, both Finn and Sam and I have been talking about, is any information that identifies an individual. That's a lot of information, not just your tombstone type of contact information. So Finn, you made my brain go to places that I will probably think about going to bed tonight. Are bacteria part of my personal information? Or are they parasites that are just happen to be hitching a ride in my body? We probably could write a good science fiction novel on that, Finn. But I think that you've got to stop at some point. And could is somebody's bacteria going to be so truly unique to themselves? And that would, Finn, you'd be able to answer that question better than I. But I think it's important to sort of stop and go, where's the harm? Where's the harm in releasing the information? Where's the harm in not? And that's part of that softness or that interpretation of the legislation. It's a risk exercise. Privacy is risk mitigation. What's the harm in releasing it? What's the harm in not releasing it? And when we're talking health information, sometimes the benefits for using it in an accountable, ethical manner far outweigh the fact that maybe at so many different levels, eventually I might be re-identified. If you're going to find the cure for COVID or the cure for cancer because of it, that's a risk worth taking, in my opinion.
No, thank you for that. And there is a question from the audience, and I wonder if we can put that up. And I think you all might have addressed this in one way or the other. I'm just going to say, so can you explain the difference between data mining and data profiling? So I'm going to open this up. Who wants to take it?
Yeah, so data profiling is Finlay was talking about metadata, right? And information about data. A lot of that is data profiling. So my impression of data profiling is that it's the data-driven analysis of the metadata, right? So it's the understanding of what's in the data, what are the values. I think one of the things we do poorly in the data profiling world is understanding what's not in the data, right? So we take a great example we've had recently with the drug information system, which I call our new data set at Health Data Nova Scotia. We've had it for 4 years. It's not that new, but I still think of it as a new data set. It has a field that is what type of prescription was written, because pharmacists are allowed to prescribe now. So we were doing research on pharmacists prescribing, and the field had recorded whether it was a new prescription or renewal or a substitution or like the different types of procedures they can make. And so we've run a lot of data profiles on this data set. And one of the types of procedures they can perform was missing. Therapeutic substitution, there were no therapeutic substitutions in our data set. Now we know that pharmacists, when you give your script to a pharmacist, they'll look at it, look at the other drugs you're receiving and say, this might be a better one for you. It's in the same class, but it works better with your other medications. That's a therapeutic substitution. And there weren't any, so we couldn't figure out why. And we ended up digging into the page 70 something of the DIS handbook that says that they don't use that code. That there's no, they code all therapeutic substitutions as new prescriptions, because from a billing perspective, which is how most of our data is captured, it didn't really matter. It was they were going to be billed the same way. It looks like a new script either way, so they just code them all the same way. That's the exact kind of thing Finlay was talking about. That's whether that falls within the scope of data profiling. I think when people talk about data profiling, they tend to talk about the very kind of spreadsheet database analytic summary of the data and not the kind of more nuanced tacit or experiential knowledge captured within the data about, it's the unknown unknowns, right? We don't know why certain values are missing from a data set, where profiling more just gets us what is captured in the data set.
Thank you so much, Sam. Anybody wants to add to that? Carla?
I guess just the concept of data mining, which is done all the time, not just in the health field, but it's basically going out and looking for data matching and then data mining, where words are put out, fields are put out. Go find this information and see if we can do something with it. And not necessarily a bad thing, even in my field, especially from a research standpoint, because if you can match certain fields together, that may be where we're going to come up with some amazing research. So not necessarily a bad thing.
I do have I was just, as Dr. Stewart was talking about the example of not having certain procedure codes, there was a relationship I found a while back that was very relevant to this, which was that doing some data mining to look at what was very predictive of good health outcomes in individuals from electronic medical records. Identify one of the strongest predictors was a blood oxygen percentage of 0%, which it shouldn't be 0%. Anything below 98, we're probably starting to look into. But it was the reading between the lines and how the data is collected, and with that kind of implicit institutional knowledge where, because Epic bugs the nurses to enter in a blood oxygen percentage on a regular basis, when the patient is fine and looks really healthy, and they this is ridiculous, I don't have time to do this, they just enter a 0. So then you end up with healthiness being associated with very low blood oxygen percentages, or a possible one. So, but I think that's where, again, I still think there's a really interesting piece in reducing the friction of accessing that implicit institutional expertise without ending up in a gatekeeping situation. So managing to have open data with implicit institutional knowledge, and how do we reduce the friction there, is a really interesting challenge that there's no universal solution for. I don't think, anyway. Professor Heggie may
Fine.
And given such amazing discussions, we have a second question now. So can we post the second question, please? Is there an industry that uses data in a way that healthcare and health research can learn from? What a great question. That would have been mine, the next one. So here we go.
I mean, it's tough. So there are certain things we can learn from the financial industry in terms of particularly the way that credit card companies manage rare events. Some of the really rare event analytics they've developed are fascinating. I think we can learn something from the way that the tech companies, I was going to say steal our data, but they don't steal it. They're very open about it. We just don't care. It's kind of made a comment about my watch. They weren't quiet. I looked through that. I know what they're taking. I just don't care because I want the information I just admitted I don't use. That Jules of her own watch. I think one of the challenges to learn from those companies is none of those companies deal with data as messy as health data. And health data is messy in a bunch of ways, but I think provenance is probably the most important. That it's always so important to know where data came from and when it was originated, because what someone was diagnosed from, it can change from point to point and never be wrong as a diagnosis evolves. I also think that you can get in trouble trying to apply other industry approaches to healthcare. And if anyone has Disney Plus, I would encourage you to watch the 8 or 10 part series that just finished last Friday, The Dropout. It's based on the blood testing startup called
Theranos.
Yeah. I didn't want to say Thanos because I did in another meeting and embarrassed myself. So it's about Theranos and the colossal failure of this company. And I think one of the challenges is that they tried to apply Silicon Valley ethics and procedures to health, and it doesn't.
They applied ethics?
The word ethics came up a bunch of times. I don't know if they applied it, but it's really interesting insights, and there are a lot of times where they're maybe even a little ham-fisted. I mean, it is still a television show about the challenges in trying to apply Silicon Valley practices to health data, where 98% accuracy isn't enough, and the things you're doing. Frankly, what we're doing with our data matters a lot more than Google's advertising to me. Google's advertising to me is a lot better and more accurate than any of my diagnostic machine learning methods we're doing right now. But that's because they can afford to be wrong about a lot of things. And but in terms of what we can take from industries, there are certain things like the big data methods and the text processing methods from the tech giants. I mean, we've been, again, not stealing because Google puts it out there. We've been using Google NLP techniques. I was recently looking at Facebook's new open software for managing distributed processes. So they have a new tool on GitHub that helps manage if you want to. Now they're doing it for like Mechanical Turk, experiments, but like if you want to kind of parallelize manual projects, they have ways to bring them together a little more smoothly. That was really interesting. Now, ultimately, I didn't apply for it because I found out too late. I didn't think it would fit. But I used PageRank, the original Google algorithm, in my PhD thesis. So we steal a lot from the tech industry, and I think the finance industry as well has some analytic methods that we can get a lot of insights from, particularly in rare event detection.
Yeah, and I think my mind went, as well as Sam's and Finn's, to the tech giants. They're not even advertisers. Google's not an advertiser. It's the world's biggest information broker. But what filters are they using? And whereas Finn said, where's the ethics? We don't know what ethics they're using, but they're making a lot of money. So I think we have to be very careful picking and choosing what formats we're going to be using from these tech giants, but they are coming up with some good technology, and they're coming up with making money. So maybe not looking at the ethical side of it, but looking at the structural side of it. How are they managing these huge, masses of information using, obviously, artificial intelligence? So maybe there's some good technology rather than the information from them. Are there technologies that we need to harness?
Yeah, and I would say the one other example would be, and regardless of some of the things again they get up to, but the pharmaceutical industry is actually one of the players in this space that actually invests money in data ontologists and data architects, and like a lot of that kind of like stuff that's not generally, outside of relatively rare things like health data Nova Scotia, is not really supported or invested in that heavily within academia because of the inherently transient nature of a lot of the people involved in academia, a lot of the projects in academia, that classic long-term funding problem that, companies like Roche, etc., they're hiring academic ontologists to help them organize, classify, analyze their data, and like work on those problems. So yeah, I think the pharmaceutical industry is also another one, which maybe isn't totally independent from health, but they are dealing with health data, but they're also investing in the kind of infrastructure to deal with it effectively.
So I'm going to ask a question. So we started with the fact that Nova Scotia is unique in many ways. We're very collaborative. I also feel like we've been around this conversation quite a bit. Like, we're talking, we're learning more, of course, in the COVID space. So what will it take? Like, what needs to happen for us to, this is important, health data is complex, but it's also that time where we need to be acting, and there are lots of things that are happening. So what will it take? A collaborative province like Nova Scotia, who needs to come together? Who needs to be at the table? What kind of partnerships? Who else are we not thinking about that should be there? So who wants to take that question and tell us how to solve this challenge?
So I think there is a lot of there's appetite for change, and I think there are, especially in the current environment, there's money where there used to just be interest. There's a little bit of money now to support these kind of collaborative environments. I think getting the right people together and getting people with the right expertise is really challenging, right? One of the challenges we have is that the people in leadership aren't aware of what's on the cutting edge. But things are evolving rapidly. When we deployed, so Health Data Nova Scotia has a cloud interface for, like, you can access the data remotely on a secure server. When we deployed it 8 years ago, it was still a private cloud. We just never used the word cloud, not once because cloud was a dirty word in health a decade ago. We're working on other projects recently, looking at establishing bigger kind of within government centralized health data repositories. And not only was the cloud solution accepted, but when the initial discussion was like the consultant suggested, you could go with this cloud solution, or you could go with, spinning your own servers at a data farm on Yonge Street. They so quickly decided we should do cloud rather than non-cloud, and nobody in government batted an eye. And this is only 8 to 10 years after we tried to hide the fact that ours was a cloud because it's a private cloud. So things are evolving, and there's an appetite. There's an appetite for cloud computing and high computing that there just wasn't before. And I think the other thing to look for is this work that researchers are doing on social license, that we might as well make good use of this data because citizens kind of think we're doing it already, right? Not only do they think it's okay as long as it's managed correctly, they kind of think we're doing it. Like they would be very disappointed to learn what some of the hurdles we've encountered in accessing our data is, because they're like, well, Google and Facebook know literally everything about me, and I can't tell this researcher that I've signed a consent form to, you can't tell them if I had a COVID test. Like there's an expectation that we're sharing data better than we are, and I think we have to work hard to meet those expectations. And I think there are people that are enthusiastic for it, but it's getting the people, the money, and the expertise lined up. And I do think we have a bit of an expertise dearth. It's not like we have analysts and database managers beating down our doors when we put job ads out. We get qualified people, but we tend to hire the qualified applicant, and we're not necessarily getting the people with those specific kind of high-tech machine learning skills that we need to be making use of this data effectively.
Thank you, Sam. Carla?
Yeah, I'd just like to add to that. I think the right people at the table are the people with the expertise that you need for whatever project. But we also go back to perception of knowledge. Just because you may read a paper does not make you an expert on something. Or you apply, my first thing I do when I'm teaching my students is to say, don't go on the internet, because there's so much misinformation if you don't know how to interpret it. Plus, there's misinformation. So I think also there's the misconception that everybody who's in computer science codes. That's all we do. We sit in a corner and we look at a monitor and we code and play computer games. There's an amazing array of expertise in technology, as well as, and privacy and information access. As I said, it's a niche field. There's not a lot of us, unfortunately, but it's changing. It's changing gradually. I feel like I'm putting a little virus, it's a little bacteria, Finn, into all my students to go out and start asking the questions, why and why not? And starting to, the expertise is coming, but very, very slowly. Like I said, when I first started in this field, everybody said, well, what are you talking about? That's ridiculous. I don't have an issue with my privacy. Now everybody has an issue with their privacy when they probably shouldn't in a lot of cases. So it's, getting the right people in the right combination.
Thank you, Carla. Finlay, do you want to add anything to that?
Yeah. I mean, I think been well covered by Dr. Stewart and Professor Heggie. Read that specific topic. But given the kind of need to have those experts at the table and like have that level of expertise to just even understand some of the data and come up with the ways we're going to share the data, how do we get to a point of actually having truly informed consent when we're consenting people to have their data shared? And I know this is a established problem in medicine, right? Like, how do you truly do informed consent for a patient when the information you're trying to impart required you to do 14 years of training? Much in the same way, kind of our expertise. And I know, like, it's kind of one of those, like, how long is a piece of string questions? There's no simple answer, but how do we manage some of those more complex aspects of consent when even us as individual researchers don't necessarily know everything that we could actually do that could be done with that data?
Can I step in?
Please.
It's
I'm
not
here to
that
you.
hard. Seriously, it's not that hard. It's specific, it's dated, it's limited, and it's informed. So you speak to the person. You don't just say, here's a piece of paper, sign it. I mean, it's the same way. How do you get people to sign off on a surgery, to give consent to have surgery? You don't just say, sign this form, I'm going to cut your leg off. It's, you need to sign this form to give a consent, and we're going to amputate your leg for the following reasons. So we're going to use your personal information for the following reasons, including research that may lead to determining that we don't have to, amputate legs going into the future. So it's communication, it's awareness, it's explaining. It's really not a major issue. I think where we run into problems in the health sector, especially when we're having, acute care and, trauma and surgeries, is, individuals fear. They're signing things they have no idea. They're getting all sorts of information. But the legislation, every piece of access and privacy legislation in this country has the word reasonableness in it. What's reasonably expected? You're not expected to know every single nuance, but reasonably what can be expected to happen with that personal information.
Thank
And
you,
if you find there's a new one, you can come back to the person and get more consent.
Thank you for that. I know we have one last question that just came through. If we can post that. A lot of health research data resides in project silos. What is a better approach beyond data sharing agreements, which don't seem to function as intended? Great question. Who wants to take that?
I mean, I can probably speak to this idea of data sharing agreements because I've been looking at so many recently. They are a challenge. They're a challenge when they fit within the especially when both parties aren't custodians, right? So a data sharing agreement between Department of Health and Wellness and Nova Scotia Health, which took a long time to get signed, is a data sharing agreement between custodians. So it's a little easier because they're both entitled to see clinical data for the purposes of clinical care. Data sharing agreements between our institution, Nova Scotia Health, or our institution and Nova Scotia Health, or Department of Health and Wellness, are more challenging. It's what I would say is that clearinghouses or larger centralized repositories where a single data sharing agreement can go. I think data sharing agreements are more effective when they're written on an institutional basis rather than a data set basis. I know that lots of groups have struggled because they work out these complex data sharing agreements between your research group and DHW on a data set, and it doesn't extend to other data sets. So we've had a lot of luck with Department of Health and Wellness when we moved our contract with them from we're giving you this data to we're going to work with you and give you data as it comes along. And the data is an appendix. I think it's often useful to think of it as that like the agreement is an agreement on how privacy is going to be secured. And then the data that's shared is an appendix. But I think centralized repositories are another solution, is to get all the data centralized in a single place and then have it cleared from there for research, because otherwise you're really trying to minimize as many agreements as possible. That being said, I haven't been super successful in the last couple of years in getting any data sharing agreements finalized. They all get stuck in legal for years on end. So I would be interested to hear what other people have to say as potential solutions to this problem.
I'm actually going to say there's one last round of questions on COVID data. So let's pose that and I'll ask the others to respond. What is one silver lining coming out of COVID around the collection and learning from collected health data that we can take as a positive outcome that will benefit healthcare going forward? Again, another great question. So please.
I will jump in on that one, having just spent all Monday having meetings related to this exact topic. So one of the major things, certainly, and this is, in my niche end rather than the kind of more broad set of health data, has been the amount of infrastructure we've stood up for COVID surveillance and COVID genomic surveillance is really enabling and has really changed, fundamentally caused a complete shift in the way medical microbiology and clinical microbiology surveillance and diagnostics can be done. So we now have all of those genome sequencers in place. We have the data infrastructure to process that data in hospitals, even major hospitals that didn't have that previously in place. So there's going to be a transformation in the way infectious disease surveillance diagnostics happen. We're going to much more quickly learn about the emergence of antibiotic resistance, for example, especially head spread in the hospital. We're going to have quicker ability to identify outbreaks and cut those chains of transmission. And we're also able to design at a more kind of then expanding from the clinical to the public health level. We're now going to be able to develop infectious disease interventions that are genomically aware and informed. So we can evaluate how well an intervention works to reduce the number of cases, but also reduce the emergence of new variants, for example. And we can look at that across social determinants of health, etc. So from my niche area, there's a lot of silver linings in terms of the genomics and pathogenomics side. And that's why I have a appointment at Sunnybrook in Toronto as pathogenomics, the shared hospital lab, medical microbiology lab owned by Sunnybrook and a few other hospitals, but to really kind of do that transformation and help drive that transformation.
I know that I can't believe we are out of time, and what a great discussion today, and I'm sure we could go on and on. So we know that there's a lot of great work that's happening, has happened. There's more that needs to happen, more people that need to come together to have this discussion. I'd like to thank a great panel, amazing discussions, and I know that you're all doing great work in your own area, but I would like to say that we know that we need action, but we also need to do that with, having that education, having the awareness, really addressing those questions and fears that people may have around this, or even encourage people to join us. Let's have patients come and talk with us. Let's have the public talk about this so we can learn from them. So I want to thank you all for this great session. It's been a pleasure hosting. I've learned so much today. And I want to thank for this opportunity as well. So we'll end on that, and thanks again.